Welcome to vpod.ai and welcome back to another deep dive. Our whole mission here really is to take a huge pile of information and boil it down to the most important stuff. Think of it as your shortcut to being truly well informed. Now, before we get started, just a quick word about our sponsor. This deep dive is made possible by Stonefly. They're your trusted solution provider and advisor for all things enterprise storage, backup disaster recovery, hyperconverged VMware, Hyper-V, Proxmox clusters, AI servers, SA365, that's a turnkey security appliance, and also public and private cloud solutions. Seriously, check them out at stonefly.com to learn more. That's STONEFLY.com. Okay, so today we're diving into Nasopharyngeal Carcinoma, NPC for short. It's a condition maybe not everyone's heard of, but understanding it clearly with empathy is so important. Our goal today is to give you a practical roadmap. We'll unpack its often hidden nature, look at how it's diagnosed, and cover the really crucial support systems out there, from the very first symptoms right through to long-term care. Understanding a complex health issue like NPC, it really can make a huge difference, especially if you or someone you care about is facing it. Just having that clarity helps you navigate what's coming next, maybe with a bit more confidence. So let's start by, pulling back the curtain on this often hidden threat. Where do we begin?
Absolutely. So nasopharyngeal carcinoma, NPC, it's a cancer that starts in the nasopharynx. Now, think of your throat, the pharynx, as this muscular tube. It has three parts. There's the oropharynx, kind of what you see at the back when you open your mouth wide. Then the hypopharynx, lower down, leading to your food pipe. And then the crucial part for today, the nasopharynx. It's that upper section right behind your nose, connecting your nasal cavity to the rest of your throat. NPC starts right there.
Okay, behind the nose. Got it. And what's the most common type?
The most common is squamous cell carcinoma, or SCC. It forms in those thin, flat cells that line the nasopharynx surface.
So a cancer in a pretty tucked away spot, and you mentioned it's not that common here in the US, but it has a bigger footprint elsewhere.
That's exactly right. Spot on. It is rare stateside, but you see it much more often in certain populations. Think parts of Asia, some Native American communities, North Africa too. That unique geographical pattern is really one of its defining characteristics.
And that location you mentioned, difficult to examine easily, plus symptoms that might not scream cancer right away. Sounds like catching it early is a real hurdle.
It absolutely is, and that's precisely why knowing the potential warning signs is so incredibly important, because the nasopharynx isn't easy to see, and those early symptoms, they can mimic less serious things like a cold or allergies, or sometimes there aren't any symptoms until it's more advanced.
So what should people be looking out for then?
Well, things like a lump in the neck that doesn't go away, that's often a swollen lymph node, that's a big one. Other signs could be nosebleeds, or even noticing blood in your saliva, headaches that persist, double vision, maybe recurring ear infections, also facial numbness, any hearing loss, a nose that always feels stuffy, or the ringing in the ears sound tinnitus, and of course a sore throat that just hangs around. If you have any of these, especially if they stick around or you have a few together, it's definitely worth getting checked out by a doctor.
Okay, that's a helpful list. And if it is NPC, how does it typically spread? What does that mean for the outlook?
Usually the first place it spreads is to the lymph nodes nearby in the neck. That's most common. Less often, it can travel to places further away like the lungs, liver, or bones, or it might grow into nearby structures like the base of the skull or the jaw. Because of these complexities, the strong recommendation is, if possible, get treatment at a center that sees a lot of these cases. High-volume centers, with teams specializing in head and neck cancers. That expertise can really matter.
Right. So given those subtle symptoms and the hidden location, just finding it can be tough. Which brings us to diagnosis. If those red flags pop up, how do doctors figure out for sure what's going on and, map out the disease?
Yeah, the road to treatment really starts with a very thorough workup. It's comprehensive. It includes getting your detailed medical history, a careful physical exam, various imaging tests, and the absolute key, a biopsy. And for anyone going through this, a few practical things can really help you feel more in control.
Like,
Well, simple things, really. Make a list of questions before you go to your appointments. It's easy to forget things in the moment. Maybe bring a friend or family member with you. They can help listen, take notes, ask questions you might not think of. And don't be afraid to ask doctors or nurses to explain things again if you don't understand. Keep all your papers, insurance stuff, test results, records organized in one place. Little things that make a big difference.
that's really solid advice. So before the high-tech scans, what are the initial health checks they do?
Well, besides checking your overall health, the team gathers a full medical history. They'll ask about family cancer history, though these head and neck types aren't usually inherited in a direct way. They'll definitely ask about tobacco and alcohol use. Those are risk factors, and they can affect how well treatment works too. A really thorough head and neck exam is standard, often using a small mirror or even a thin, flexible scope with a camera. And this is crucial. A dental exam before any treatment starts. Radiation can have long-term impacts on your mouth, so getting that checked is vital. They also screen for emotional distress, anxiety, depression, and check things like your vision, hearing, nutrition, and your ability to speak and swallow. All this helps tailor the plan just for you.
Okay, that makes sense. Laying a good foundation. Then come the imaging tests to actually see inside.
Exactly. Imaging is key to see the tumor, how big it is, where exactly it is. You'll likely have several types. A CT scan, sometimes called a CAT scan, uses X-rays to create detailed cross-section pictures, often with a contrast dye to make things clearer. An MRI scan uses radio waves and strong magnets. It gives different details than a CT. And if claustrophobia is an issue, sometimes an open MRI is an option, which feels less enclosed. Then there's a PET-CT scan. This uses a radioactive sugar tracer. The idea is cancer cells are more active and gobble up more sugar, so they light up on the scan. It's really good for spotting cancer that might be hard to see otherwise, or checking if it's spread. And ultrasound uses sound waves. It's often used to look closely at lymph nodes in the neck and frequently helps guide the needle for a biopsy.
So all these scans build a really detailed picture, but the biopsy is the final word, right? To confirm it's cancer and know exactly what kind.
Precisely. The biopsy is the definitive step. No diagnosis without it. It means taking a small sample of tissue or fluid, often guided by ultrasound or CT, which a pathologist then examines under a microscope. This confirms, yes, it's cancer, and tells us the specific subtype. Like we said, usually squamous cell carcinoma, but knowing for sure is critical for planning the right treatment. They might use a fine needle, called FNA, or a slightly larger core needle biopsy.
And there's this really interesting link with a virus, right? Epstein-Barr virus, EBV, how does that fit in?
Ah, yes, the EBV connection. This is fascinating and incredibly important, especially for MPC. Most nasopharyngeal cancers, particularly the types common in those areas we mentioned, like parts of Asia, are linked to EBV. What's become really powerful is testing for EBV DNA. They can measure the levels of viral DNA in your blood. And these levels, the amount of EBV DNA in the plasma, correlate directly with the stage of the disease, how well treatment is likely to work, and even overall survival.
Wow, so it's like a biomarker. It tells you something about the cancer's activity.
Exactly. Think of it like a sensitive radar for the cancer. We can track these EBV DNA levels before, during, and after treatment. If the levels go down, treatment is likely working. If they stay high or rise again, it could signal recurrence, sometimes even before it shows up on a scan. It's become a really valuable tool for prognosis, for monitoring, and even potentially for screening high-risk people. It's a game changer in managing NPC.
It's incredible how all these tools, especially that EBV monitoring, come together to paint such a detailed, personalized picture. So once all this info is gathered, the doctors stage the cancer. What does staging mean practically for the patient?
Staging is basically creating that roadmap for treatment we talked about. It tells everyone involved how far the cancer has progressed. We use the standard T&M system. T for the size and extent of the primary tumor, N for whether it's spread to nearby lymph nodes, and M for metastasis, meaning has it spread to distant parts of the body. This staging, usually given as a number from 0 to 4, with 4 being the most advanced, is vital. It helps predict the likely course, the prognosis, and most importantly, it directly guides the treatment choices. You might hear about a clinical stage based on test before treatment, and sometimes a pathologic stage if surgery is done, which can be more precise.
Okay, roadmap created. Now for the journey, treatment. Who's typically on the care team for NTC? It sounds like it takes a village.
It absolutely does. Treating NPC effectively requires a real team effort, a multidisciplinary team. You'll likely work with an otolaryngologist, that's your ENT, ear, nose, and throat specialist, a medical oncologist who handles the cancer drugs, a radiation oncologist, the radiation expert, sometimes a surgical oncologist, though surgery is less common for the primary tumor here. And then there's a whole support crew. Oncology nurses, pharmacists, speech-language therapists, and swallowing therapists, really important given the location. Psychologists or psychiatrists for emotional support, and social workers to help navigate all the practical stuff, like insurance or finding resources.
That's quite a team.
It is, and the most important message for anyone going through this is, you know your body best. Your input, your voice is critical. Talk to your team. Tell them how you're feeling, what your concerns are. Open communication is key.
That's so important to hear. So what are the main treatment strategies they use for NPC?
The cornerstone, the standard approach for most stages of NPC, is usually a combination of radiation therapy and systemic therapy, often given together, which we call chemoradiation.
Okay, let's break that down. Radiation therapy first. How does that work?
Right, radiation therapy, or RT, uses high-energy rays like X-rays to kill cancer cells and shrink tumors. For NPC, the most common type used today is intensity-modulated radiation therapy, IMRT. It's very precise. It shapes the radiation beams to closely match the tumor shape, which helps deliver a high dose to the cancer while minimizing damage to surrounding healthy tissues. You might also hear about proton beam therapy, another very precise form of radiation. Now, RT does have potential risks. It can sometimes cause narrowing of the carotid arteries in the neck over time, increasing stroke risk later. And as we mentioned, that pre-radiation dental check is absolutely essential because of potential long-term effects on teeth and jawbone.
Makes sense. And the other part was systemic therapy. How's that different?
Systemic therapies are treatments that travel through your bloodstream to reach cancer cells pretty much anywhere in the body. There are three main categories. Chemotherapy uses drugs that kill cells that divide rapidly, which includes cancer cells, but also some healthy cells, leading to side effects. Targeted therapy is more specific. These drugs target particular molecules or pathways involved in cancer growth. And then there's immunotherapy. This is a really exciting area. These drugs help your own immune system recognize and attack the cancer cells, kind of like taking the brakes off the immune response. Examples of drugs. For chemo, things like cisplatin or gemcitabine are common. For immunotherapy, you might hear names like pembrolizumab or nivolumab. Often, these are used in combination.
Okay, chemo, targeted immunotherapy. How do they decide which treatments to use based on the stage of the cancer?
Great question. Treatment is very much tailored to the stage. For early-stage NPC, maybe stage 1 or 2, radiation therapy just to the nasopharynx and possibly the neck lymph nodes might be enough, or sometimes chemoradiation. For locally advanced disease, meaning it's spread nearby but not distantly, like stage 3 or some stage 4 clinical trials are often recommended if available. Otherwise, the standard is often chemotherapy first, followed by chemoradiation, or just chemoradiation alone. If it's metastatic disease, meaning the cancer has spread to distant parts of the body like the lungs or liver, the main goal shifts. Treatment focuses on controlling the cancer and managing symptoms. This usually involves systemic therapy, chemo, targeted therapy, or immunotherapy, sometimes combined with radiation to specific spots. Or it might be best supportive care, focusing purely on quality of life.
And what if the cancer comes back after treatment or doesn't go away completely?
That's called recurrent or persistent disease. Surgery is still rarely an option for the primary site because of that tricky location. So treatment really depends on what you had before, especially how much radiation and if the recurrent tumor could potentially be removed, resected. Options often involve more chemoradiation, maybe different drugs, possibly more focused radiation like SPRT or systemic therapy. And again, clinical trials are often a really important option to explore here, looking for newer approaches.
It really sounds like the treatment landscape is evolving with these personalized strategies and clinical trials pushing things forward. Can you tell us a bit more about clinical trials? What should people know?
Clinical trials are absolutely vital. They are research studies designed to test new treatments or new ways of using existing treatments. They're how we make progress against cancer. They happen in phases. Phase I looks mostly at safety and dosage. Phase 2 checks if the treatment works. Phase 3 compares the new treatment to the current standard treatment. A common concern is about placebos, the sugar pills. In cancer trials, it's extremely rare for a placebo to be used alone. If a placebo is used, it's usually the standard treatment plus the new drug versus the standard treatment plus a placebo. You always get at least the standard care. And importantly, the costs for the research part of the trial, the new drug or extra tests, are usually covered by the trial sponsor. Patients provide informed consent, meaning they fully understand the trial's purpose, risks, and potential benefits before agreeing to join. Definitely something to discuss with your doctor, asking, are there any clinical trials that might be right for me? It's always a good question.
That's really helpful clarification. Okay, this definitely raises a big question. We've talked about the medical side, but what about coping, both emotionally and physically? Knowing about the potential challenges and the support that's out there seems crucial for patients to advocate for themselves and maintain quality of life.
Absolutely crucial. Coping is a huge part of the journey. A cancer diagnosis brings a whole wave of emotions: sadness, fear, anxiety. It's completely normal. That's why distress screening is now a standard part of good cancer care. Hospitals routinely ask about your emotional well-being. It's so important to talk about how you're feeling with your care team, with friends, family. Don't bottle it up. Counseling services, psychologists, psychiatrists are part of the team for a reason. And support groups, whether they're in-person or online forums like Cancer Chat, can be incredibly helpful. Connecting with others who get it makes a real difference.
And the physical side effects. Head and neck treatments can be particularly tough, right?
They can be, yes. Most people will have side effects, and managing them well is key. The mouth and throat often take a hit from radiation. Soreness, ulcers are common, sometimes needing prescription mouthwashes or strong pain relief. Dry mouth, what we call xerostomia, is very common and can unfortunately be long-lasting. It makes eating, swallowing, even talking difficult, and increases risk of dental problems. Your sense of taste can change too. Food might taste metallic or just bland.
And fatigue. I hear that's a big one.
Huge. Cancer fatigue is different from normal tiredness. It's often described as overwhelming bone-deep exhaustion that rest doesn't always fix. It tends to get worse during treatment. Pacing yourself, allowing for rest, but also trying gentle exercise like walking can actually help combat it. A balanced diet and fresh air are important too.
What other side effects might people experience?
Well, you might have skin changes in the area treated with radiation like a sunburn, sometimes peeling or soreness. Hair loss just in the treated area is possible. Difficulty chewing and swallowing is common, which is where speech and language therapists are invaluable. They provide exercises and strategies. Sometimes a temporary feeding tube might be needed to ensure you get enough nutrition. Less common, or later effects, can include changes in your sense of smell, maybe thyroid or pituitary gland issues if they were in the radiation field, eye problems too. We mentioned dental issues. The risk of cavities and jawbone problems increases, so super diligent dental care and fluoride are essential long-term. Lymphedema, that swelling in the head or neck from fluid buildup after lymph nodes are treated, can happen and needs specialist therapy. Nausea and vomiting can occur, especially with chemo. Some people experience chemo brain or neurocognitive effects, issues with memory or concentration, and neuropathy, numbness, or tingling, often in hands and feet.
Wow, that's a lot to potentially manage. How do people cope with all that?
The absolute number one thing is communication. Tell your care team about everything you're experiencing, even if it seems small. There are ways to manage almost all these side effects. Pain management is key. Keeping a pain diary can really help track it and communicate effectively with your team. There are pain specialists too. Beyond medications, things like maintaining a balanced diet, staying hydrated, gentle exercise, yoga, acupuncture, massage, these holistic approaches can make a big difference in managing side effects and improving overall well-being.
It's really impressive, the range of support for the physical side. What about the practical day-to-day challenges, finances, work, getting help at home?
Those practical aspects are hugely important and can cause a lot of stress. But help is available. Social workers in the hospital are fantastic resources. They can help you navigate financial concerns, understand benefits, sick pay, maybe find grants for things like prescription costs or travel to appointments. They can help with work issues, arranging time off, or even things like applying for disabled parking badges. For help at home, your GP and community or district nurses can provide medical support, give injections, help with wound care, and offer emotional support too. There are also community palliative care nurses who specialize in managing complex symptoms like pain, whether the cancer is advanced or not. And organizations like Marie Curie offer nursing care at home, especially for those with more advanced illness, giving families much-needed respite. Social workers can also help arrange practical things like home helps or meal delivery if needed.
And one last thing for long-term health smoking.
Yes, absolutely critical. If you smoke, quitting after diagnosis and treatment is one of the best things you can possibly do for your health. It significantly cuts the risk of the NPC coming back or of developing a new head and neck cancer or other smoking-related cancers. Plus, it helps reduce treatment side effects and improves your overall recovery. Your care team can definitely point you towards resources to help you quit.
Okay. We have certainly covered a lot of ground today. From really understanding the hidden nature of nasopharyngeal carcinoma through that detailed diagnostic journey, the tailored treatment plans, and all the layers of support available, it's clear that facing something like NPC is incredibly complex, no doubt about it. But hopefully what we've discussed shows that with clear information, with a dedicated team in your corner, and by actively advocating for your own needs, you really can navigate this journey more effectively, and you are definitely not alone. So here's something to think about. As you face complex health choices, maybe for yourself or someone you love, how does actively building that network of knowledge, whether it's from experts or peers or community resources, How does that empower you to not just get through challenging times, but potentially find ways to truly live well within them? This deep dive was brought to you with the support of Stonefly. And hey, before you go, don't forget to check out Stonefly's incredible offer, a 100 TB immutable and air-gapped SSO NAS for just $8,995. That's stonefly.com. Thank you so much for joining us for this deep dive. We really appreciate you tuning in, and we'll catch you on the next one.